Anemia. The worldwide anemia is commonest red cell disorder. Anemia leads to decreased amount of hemoglobin concentration, red cell count, and PCV value. The anemia is present when hemoglobin concentration falls below in the following: newborn 14 grams per deciliter, child 6 months to 4 years 11 grams per deciliter, child 5 to 11 years 11.5 grams per deciliter, child 12 to 14 years 12 grams per deciliter. Non-pregnant women 12 grams per deciliter, pregnant women 11 grams per deciliter, men and adult boys 13 grams per deciliter. In tropical and developing countries, anemia is seen in 15% or more of preschool children, and in pregnant women it is a moderate or severe. The main causes of anemia includes malnutrition, protein deficiency, folate deficiency, parasitic bacteria, and viral infections, or it may be inherited. Classification: anemia may be classified into two types based on morphology of red cells or up to etiology, that is cause of anemia. Based on morphology classification, it is divided into MCV, MCH, MCHC, and red cell morphology on blood smear. Normochromic normocytic anemia. In this type of anemia, their RBC are normal size and color, but reduction in number. The packed cell volume is reduced. MCH, MCV, MCHC are normal. The normocytic normochromic anemia may be found in acute blood loss anemia of chronic disease, aplastic anemia. Hypochromic microcytic anemia. The red cells are small and pale, decrease in total RBC count, low HB and PCV, reduced MCV, MCH, MCHC. Hypochromic microcytic anemia, it is found in iron deficiency anemia and thalassemia. Normochromic macrocytic anemia, the red cells are large in size with no central pallor portion. The RBC are reduced in number with low hemoglobin, elevation MCV and MCH and normal MCHC. Normochromic macrocytic anemia is found in pernicious anemia, anemia of folic acid and vitamin B12 deficiency, in some cases of aplastic anemia. Normochromic microcytic anemia, the RBC are small in size with low HB, reduced MCV, MCH and normal MCHC. This type of anemia is found in some of the anemia of chronic infections. Etiology classification: based upon the causes of anemia, the following type of anemia are found. Aplastic anemia, it may occur due to the congenital defect, that is chromosomal abnormality in RBC, or exposure to various physical and chemical agents like insecticide, streptomycin, ionizing radiation. Usually RBC are normal, but sometimes anisocytic or poikilocytosis may be seen. Decreased WBC count, decreases platelet. Bleeding time is increased. Bone marrow is aplastic, rapid ES or aplastic anemia may be terminate as leukemia. Iron deficiency anemia, the normal adult body contains 4000 milligrams of iron. About 60% of this iron is present in circulating body. The remaining is stored in the liver and reticuloendothelial cells of bone marrow. When iron is present, utilized by the RBC at a faster rate, and the dietary intake of iron is insufficient to keep up with the increased use, the iron stores in the body is used for the synthesis of hemoglobin. When the iron stores become exhausted, the iron deficiency anemia results. The microcytosis, hypochromia and poikilocytosis are associated with iron deficiency anemia. The reticulocyte count is normal. The serum iron is increased. It is commonly seen in early stage of life during pregnancy. Pernicious anemia, this disease is caused by vitamin B12 deficiency, intrinsic factor which is increased for absorption of vitamin B12 is not secreted by gastric mucosa. This type of anemia is generally found in patients above age of 60 years. It is associated with the weakness and shortness of breath, the abdominal pain, diarrhea, nausea, pain and sore throat. The laboratory findings are macrocytic normochromic RBC, moderate to marked anisocytosis and poikilocytosis. Serum bilirubin may be increased. Hemolytic anemia, the hemolytic anemia are characterized by a fall in hemoglobin, jaundice, dark urine, increased reticulocytosis. It may be hereditary or acquired. The red cells are usually normochromic microcytic. The serum plasma appears yellow due to the increased bilirubin. Hemoglobin and hematocrit varies from normal to extremely low level. Coombs test is positive. Sickle cell anemia, In this case, the red cell contain 90 to 100% of the hemoglobin S, and the remaining hemoglobin F is associated with severe abdominal bone and joint pain, enlarged spleen. The sickle cell are found in blood. Reticulocytes and platelets are increased. The osmotic fragility of RBC is decreased. Sideroblastic anemia. The sideroblastic anemia may be hereditary or acquired. In case of hereditary sideroblastic anemia, it may present at birth or during infancy and usually manifest in adolescence. The RBC are hypochromic and microcytic. The increased serum iron level, moderate anisocytosis and poikilocytosis. In case of acquired sideroblastic anemia, the normochromic RBC but very few or hypochromic red cells. It is found in adult above 50 years of age. Thalassemia, Cooley's anemia, in hereditary blood disease widespread in Mediterranean countries, Asia and Africa, in which there is abnormality in the protein part of hemoglobin molecules. The affected red cells cannot function normally, leading to anemia. Other symptoms include enlargement of spleen, abnormalities of bone marrow. Individuals inheriting the disease from both parents are severely affected. This is called thalassemia major. Those inheriting from single parent or thalassemia minor, those are usually symptoms free. Patients with a major disease is treated with a repeated blood transfusion. The disease can be detected by prenatal diagnosis, including the amniocentesis Schilling test. The Schilling test is the test for diagnosis of vitamin B12 deficiency. In this test, the first give 1 milligram labeled vitamin B12 parentally to the parent, then give 1 milligram labeled B12 orally. It is labeled with cobalt 57 within 24 hours. 1/3 of observed labeled radioactive vitamin B12 is fused out in urine. The normal excretion is above 10% of oral dose. In anemic patients with vitamin B12 deficiency, patient excretes less than 5%. If the test is normal, no further testing is necessary. If it is abnormal, repeat the said procedure with simultaneous oral administration of intrinsic factor, that is vitamin B12 binding protein. If excretion increases, it implies lack of intrinsic factor. It does not, then there is some defect in absorption. The test should be repeated after 48 hours.